Hi, I'm Dr. Lorraine Dontigny, Obstetrician-Gynecologist at VM downtown Montreal. Today we'll be talking about a particular issue of mood, sleep, and cognition in the perimenopausal period. And to do so, I have a very special guest, Dr. Denise Black, who's a key leader in menopause in Canada. Dr. Black is also a fellow of the College of Surgeons of Canada, and she's an assistant professor of University of Manitoba. Hi, Dr. Black. It's such a pleasure to have you with me today.
Thank you for asking me to be part of this project.
So, as I mentioned, I have a task for you, and you have to help us understand the problem of mood, sleep, and cognition happening in the perimenopausal period. I saw a patient last week, 49, 50 years old, and she came to me with papers and a list on her paper. And she said to me, "You are the fourth or fifth doctor that I come to see. And I hope you're going to be able to help me because you are actually my last hope. So many things are happening in the past 6 to 12 months, and I don't know what's happening with me. I have a problem concentrating, and I'm at work, and I can't remember things. I leave home to go to work, and I forget my cell phone, or I forget my keys. And work is not bad, but it seems to take me so much more time to accomplish what I used to accomplish in a much smaller time. And then I get home, and I have no energy to accomplish all the chores I should be doing. I get irritable so easily, and then I start crying for no reason. And then comes the night, because when I go to bed, I don't know if I'm going to sleep. I don't know how I'm going to sleep. I don't know how many times I'm going to wake up through the night, and will I be able to fall asleep? I wake up drenched from hot flashes and night sweats. And then when it's time to wake up in the morning, it takes so much out of me to drag myself out of bed, and I'm even more tired than when I went to bed. So, Dr. Black, what is happening? Am I just aging? What's going on?
You know, it's distressing. So these are absolutely typical symptoms that I hear from menopausal women. It's just really distressing to me that that is our patients' realities. Now, just to put a perspective on this so we understand the scope of the problem, 85% of women will experience symptoms during the menopause transition. So we know that that's a time of very high symptomatology, and the next few years after can be very symptomatic as well. The average duration of hot flushes is 7.5 years. Of the 85% of people that experience symptoms, 1/4 to 1/3 will describe their symptoms as severe or frequent. And the scope of this is that it's estimated that women age 45 to 60 make up 25% of Canada's full-time workforce. 15% of those women with severe hot flushes will actually quit their jobs. So this results in two things. The workplace loses an experienced, valued employee, but that woman also sets herself up at a financial disadvantage. She will have less savings, potentially less pensionable earnings, and may be looking at poverty in older age because of this.
So, can you explain to us or give us some background that explain all of these symptoms that are intertwined?
First, just to validate, brain fog, as your patient described, is very common. In fact, it's almost universal. And some of the symptoms of brain fog may be things like difficulty maintaining a train of thought, distractibility, and forgetting your intentions, like walking into a room and then forgetting what you came there for. Thankfully, things like executive high-order brain function and complex problem solving remains relatively unchanged. But very specific to the menopause transition is issues with verbal memory dysfunction. Someone will tell you something and 30 seconds later it is gone from your brain. So when someone comes to you with these symptoms, it's important to reassure them and say, menopause brain fog, really common, and then to validate the specific realms that they may notice that they're having some difficulties. And the reason that people have issues with verbal memory dysfunction, it's because your brain has to adjust to find different ways to encode information or memories as specific parts of your brain adjust to lower estrogen levels. Now, I'd like to introduce you to a model that helps to explain some of these things, and Dr. Pauline Mackey and Dr. Nicole Jaffe created this model and made it available for us to help explain some of these things. It links many of the biological changes going on at menopause with some of the brain symptoms. Verbal memory dysfunction is the most common brain symptom experienced. So verbal memories are stored in a specific part of the brain called the hippocampus. And the hippocampus has a lot of estrogen receptors. When estrogen levels start to fall, and this happens in the early perimenopausal period, the hippocampus starts to not work as well. When estrogen levels really start to decline, which is late in the perimenopause or early postmenopausal period, the brain feels a need to do something different to adapt. So it adapts by switching older verbal memories to a different part of the brain. This potentially frees up storage space in the hippocampus so that new verbal memories can be stored. Unfortunately, this moving of old memories is not a quick process. It often takes 2 to 3 years. Unfortunately, adding estrogen therapy does not seem to make this process quicker, but it's important to let patients know that it is time limited. The next thing I'd like to address on the model is the impact of low mood on brain function. And the menopause transition is a period of vulnerability for mood disorders. Especially vulnerable are people with a prior history of hormone-sensitive depression, such as severe PMS or postpartum depression. People with a prior history of depression have an increased risk of reactivation, and even the general population with no prior history of depression has about a double risk of developing depression during the menopause transition. And it's not just about the hormones. If you think closely about it, the menopause transition really is a time of great psychosocial change as well. Changes in work responsibilities. Perhaps there's teenagers or young adults at home that are causing distraction or requiring some support. There's the challenges of long-term relationships, the challenges of pandemics, and sometimes it's just the perfect storm of factors for people that are susceptible. And low mood and anxiety absolutely affects overall brain function. But it's somewhat unclear whether treatment of mood issues results in a complete rebound of brain function or just a partial rebound. The next thing on the model is sleep, and sleep is critically important. There's really robust data that suggests that sleep deprivation has a direct relationship to learning issues. So people with disturbed sleep or sleep that hasn't been very restful may actually have more difficulties with verbal learning and difficulties with memory. Things that cause poor sleep might include menopause symptoms like hot flushes and night sweats. It might be musculoskeletal pain. It might be low mood or anxiety where you're worrying about, am I going to fall asleep? How is this going to impact my performance during the day tomorrow? I have something really important to do. I better sleep well tonight. Sleep apnea, snoring in either you or your sleep partner, restless leg syndrome. All of these things may cause poor sleep, and poor sleep can worsen anxiety, mood, memory, and increase the risk of heart disease. So with sleep, it's often a vicious circle where the less sleep you get, the worse everything else gets. Finally, on this model, I want to talk a bit about vasomotor symptoms. Now, these are more commonly known as hot flushes or night sweats. They're uncomfortable, they're embarrassing. They can prevent sleep and interfere with mood and brain function. But also, there's new evidence now that they can cause significant physical damage to your brain. And I'd like to introduce now some MRI images from some recent work done by Doctors Rebecca Thurston, Pauline Mackey, and their collaborators in the United States. So they examined the brain MRIs of 226 women aged 45 to 67 who were not on any hormone therapy and who were experiencing vasomotor symptoms. On the MRIs, they looked for something called white matter hyperlucencies that you see in the MRI scans, especially on the right-hand panel. These white matter hyperlucencies indicate irreversible scarring and irreversible damage to the actual brain matter. They are early indicators of risk for cognitive decline, dementia, and stroke. The MRI on the left panel was representative of people who had a medium amount of hot flushes, maybe 2 or 3 per day. You can see that there's a little bit of white, but overall the brain structure looks pretty normal. On the right is a representative MRI of women having frequent and severe hot flushes. In their study, they were averaging 20 in a 24-hour period, with an average of about 5 at night. You can see how much damage has happened in their brain. Those with hot flashes during the night, whether or not they woke up, had the highest amount of brain damage. Now, this is very sobering information when we consider long-term brain health of women.
I agree. That's impressive and shocking. And I hope it will awaken people to take charge of these moderately to severe hot flashes. Thank you so much, Dr. Black, for enlightening us about this specific and so overwhelming issue of mood, sleep, and cognition in the perimenopausal period. Thank you, Dr. Black.
Thank you.
In the next segment, we'll be discussing how to take charge of these mood, sleep, and cognitive issues and all the therapeutics involved. So stick with us.